Welcome to Dental XP. I'm Dr. Maurice Salama, and today we're going to be presenting a surgical video on the treatment of the deficient posterior maxilla, dealing specifically with access to sinus grafting and some of the new protocols involved in sinus grafting. In the Panorex you see before you in the maxillary left side, in the area of the second bicuspid and first molar, you can see a pneumatization of the sinus, quite severe on the first molar site, and then sloping upwards as we get to the second bicuspid. And the sloping sinus poses some challenges for us, as we're going to see in the video being presented. And you'll see here on the in the second bicuspid space that we have about 5 to 6 millimeters to place our implant to secure it and stabilize it, but as we go above that area we get into the sinus. In the area of the first molar we only have about 1.5 millimeters of bone to secure the implant, and the rest is in a largely pneumatized sinus. So we have two different types of sinus issues to deal with, and if we look at this on the cone beam image we can see that we only have a little bit of crestal bone to deal with on the molar site, but 5 to 6 millimeters on the second bicuspid. So we have that ledge or slope, as you can see quite clearly on these 3D images. So what we're going to share with you today is two different accesses to the sinus, one crestal and one lateral. And this is the clinical view of the case you just saw. We're going to utilize a broad-based vertical incision that's going to go beyond the mucogingival junction and include the mesial papilla of the first bicuspid. I like to utilize a full sulcular incision with a lingual crestal approach over the edentulous span. And I can tell you that a sloping sinus floor poses some challenges if you're going to attempt to do this kind of procedure with either crestal or lateral window approach. And we're going to talk about this in just a moment. And you can see again the sulcular approach going on the mesial of the molar as we go to reflect the underlying osseous topography. A Boozer microperiosteal elevator is utilized to engage and lift the papilla on the mesial aspect of the flap, and then a microperiosteal elevator to initiate the crestal release. So it was important, if you're going to be doing a sinus lift where you are in fact going to have a lateral approach as well, you want to make sure that you have full flap thickness and expose the underlying osseous topography. And this is being done here. Any type of movable tissues are removed from the crest so we have a clear view of the underlying bony anatomy. I also make sure that I clean off any of the loose tissues that approximate the adjacent teeth, as I feel that those tissues are potential granulomatous tissues that may in fact enter into the sinus while we're working. So we like to disinfect that area. There's two common approaches today, one being a crestal approach, and here utilizing the Neobiotech drill system, we can actually enter the sinus through a vertical approach. Now, if you're not going to be using a wide diameter implant, I really find the crestal approach a little bit challenging for a small diameter, but I want to go through the exercise here. You can see on the second bicuspid, because of the depth, utilizing a crestal approach becomes a little bit daunting, as it's 5 to 6 millimeters in depth before we get to the sinus. But in the area of the first molar, a 2 millimeter Neobiotech crestal drill kit. These are neurosurgical burrs which will cut bone but will not cut the Snyderian membrane or soft tissue. And what it does, it actually builds bone on the end of the drill, and it forms a protective bony disc that prevents laceration of the soft tissue of the Snyderian membrane. Now, this is a very, very nice tool. And if both areas were pneumatized the same amount, if there wasn't a sloping shoulder in this case, a sloping floor of the sinus, then a crestal approach in this case would have been an ideal choice. And you can see me going through the procedure on the first molar site because I knew that I was only 2 millimeters from the sinus. And you can see I can gain very good access here. This is a 3 millimeter hole, and you can see the sinus has not been torn. It's completely intact. And I can now, utilizing the depth gauge with a rounded edge instrument, just simply make contact with the sinus floor, and I can lift this with instruments or a balloon. But because I can't do this on the second bicuspid site, because of the sloping shoulder, I prefer instead to go ahead and utilize a lateral approach. So I'm now going to utilize the Neobiotech lateral sinus kit. This is, again, a neurosurgical burr that allows us to enter through the lateral wall without damaging the Schneiderian membrane. These neurosurgical burrs turn at 2,000 RPM with copious water irrigation. The same concept, it creates a bony disc in front of the drill that protects the Schneiderian membrane. And you can see this beautifully exemplified in this video as we just go ahead and irrigate this area. You can see the Schneiderian membrane on the corners around the hole, and then in the inside, the remnants of that bony disc that's pushed in front of the drill. This is a beautiful system. It allows access, and we can do large, these are about 6 millimeter wide drills, and we can combine multiple sites and drill these next to one another to enlarge the access that we have for the sinus. In this case, I'm doing that. And then to remove the remnants of the bony disc, I'll then use a piezoelectrical device. And today, I've utilized multiple devices. NSK has an excellent system, Salvin as well, and many, many others. And this allows us now to utilize the piezo just simply to start the lift of the Schneiderian membrane. This is the special elephant tip that we can utilize. This is on a special setting. Again, it will only just very gently lift the Schneiderian membrane. It does not traumatize or damage that membrane at all, which is a key to a successful sinus graft procedure. Only after we remove the remnants of the bony discs and we initiate with the special instrument the lifting of the Schneiderian membrane do we then enter with the initial sinus lift instrumentation. It is always important to start your lift at the floor of the sinus and then work your way mesial and then distally. I never go vertically. I work my way mesially, as you see very nicely here. The membrane is completely intact and there is no tear of this membrane. Only then will I work distally. After I get the floor raised and I get the mesial turned, I then use these types of very curved instruments that allow me access to the distalmost area just buccal to the second molar. This instrument allows me to continue this lift as I now work my way from the floor towards the medial wall. And this is often where people have the most challenge. The periosteum in the sinus has a high regenerative potential. It's important to expose as much of that as possible, and that extends our sinus lift always, whenever possible, with a lateral approach to the medial wall of the sinus membrane. You can see when the patient breathes that the sinus is intact. I always utilize a fibrin bioactive material in the sinus that I introduce, number one, for the bioactivity, number two, for the sticky and fibrin nature of the material that will close off and seal any type of micro perforations of the sinus membrane that may exist that we may not be able to see. I then introduce PRGF liquid, again, plasma-rich in growth factors taken from the patient's blood. Today, some people would utilize bone morphogenic protein or infuse. Again, some people just using fibrin alone and no bone graft material whatsoever. I, in this case, feel always more comfortable utilizing this in combination, both the PRGF material and the bone graft mixed with the bioactive material. You can see it forms a sticky nature, so I can carry that bone material into the sinus. In this case, this is mineralized irradiated bone mixed with PRGF, and always pack the medial wall of the sinus first. It's very important that we do the medial wall first because it's easy access. And then only after you do the medial wall do you then go ahead and go towards the anterior wall and medial wall in combination. At the very end, once you've done the anterior portion of the sinus, then the medial wall, you then complete the packing of your bone graft material on the distal aspect, proximal aspect of the sinus, and then fill the lateral access. Again, I don't believe that we have to use much more than 2 to 3 grams of material. Sometimes there's a tendency to place more bone than we need in the sinus, and I just don't believe that that's necessary any longer with the bioactive modifiers that are being utilized. Lightly packing this in, I do want to fill the area where I'm going to be placing my implants. I do not have to fill the sinus beyond the area where I'm going to be placing my implants. Often a mistake is to use several grams of material and to obliterate most of the sinus, and sometimes causing problems if there is a tear by introducing bone into the area where the sinus has not been lifted. Here's the bone graft being placed. You can see tamping it down, not as much a pack, but tamping that material down so that it's collated and together, but not densely packed, so that we have the potential for blood and angiogenesis to perfuse through the bone graft during the healing phase. I utilize, again, a fibrin autologous membrane taken from the blood to cover the window access. This can be done in combination with a collagen barrier and fibrin. In some cases, I believe that utilizing a long acting collagen barrier in addition to the fibrin may be also well utilized. In this case, we're going to utilize 2 BioHorizons tapered internal laser lock implants. They're going to be inserted. I'm going to drill very, very lightly with very limited water irrigation, just to be able to get beyond the bony structure on the crest of the ridge. And I under-prepare this area so that I can get good initial stability. It's very important that you don't go to the final drills here. I just very, very gently go down so that I can get the drill before the 3.8 millimeter drill, therefore allowing me to secure the implant on the top 2 millimeters of bone that is present below the sinus. And we're going to utilize the laser lock implants, placing the laser lock, in this case, flush with the crestal bony walls, or slightly above. And again, PRGF placed on the surface of the implant before insertion. And you remember this is the sloping part of the sinus floor, where we had about 5 millimeters, 6 millimeters of bone to secure the implant before it enters the sinus. You can see I had to go down in this case and ratchet this implant beyond 40 Newton centimeters to get the implant all the way down into its position. So the implants are basically now being placed into the grafted sinus walls. The laser lock at the top of these BioHorizons implants allows us the ability to place them either flush with the crest or just a 0.5 millimeter above the crest, so to coincide the laser lock channels with the connective tissue of the flap. You can do it either way. It does give you the ability to have the variability of placing the top of the implants either supracrestal or crestal. Again, paralleling the implants to allow for the screw access channels to come out through the future occlusal surfaces of the final restorations. We are going to utilize cover screws. In this case, I don't like to do these as one-stage procedures, even though they're stable implants. I think it's best to just uncover them at a secondary procedure. You can see from the crestal view, these implants have complete bony walls around all sides. We have good initial stability of the implants, and now we can add additional fibrin on the buccal aspect in multiple layers to protect the sinus window and to further enhance and graft the buccal bone. This material is very workable. You have about 2 minutes of working time with this fibrin before it starts to set. You can see it turns from a bright yellow consistency to a pale consistency. That's when it starts to set. And this material will continue to protect the graft, secure it, act like a membrane, keeping out the soft tissue of the flap from the bone graft of the lateral window of the sinus. And we were able to really introduce two different access techniques for the sinus today, either a crestal approach or a lateral approach utilizing the neurosurgical drills that were highlighted here today from NeoBiotech. Now what's interesting in these cases, again, if we had a flat floor of the sinus, I think that the crestal approach would have worked beautifully for both implant sites, but in the case of a sloping sinus floor, as you saw here, I believe, and you're not going to place wider diameter implants, much easier to just simply perform the lateral window technique. Now we're going to go ahead and utilize a Gore-Tex suture. A polytetrafluoroethylene suture is then utilized again in a horizontal mattress for the first suture to get complete closure over the fibrin and over the implants. We're going to do this to attain primary closure, and we're going to do this procedure as a two-stage procedure. The first suture to me is always the most important as it approximates our wound edges. And you can see the sling suture coapting the keratinized tissue of the buccal flap with the keratinized tissue of the palate. We have good thickness, and we should be able to easily manipulate this tissue at surgical uncovering to maintain good ridge form and keratinized tissue on both sides of the future permanent abutments. It's one of the things that I think about most often today is the tools that allow us to do this in a very atraumatic fashion. The keys to success, again, are to minimize trauma, to make sure that we don't tear or perforate the Schneiderian membrane, that we don't overpack the sinus, that we protect that sinus window. These are all keys to success in any sinus procedure. The fact that today we have the ability to perform these through a crestal approach, which I've shown before on this site, or if we're going to use wide diameter implants, utilizing maybe a technique like Dr. Samuel Lee's kit here that he utilizes on this site to access for wider diameter implants, a crestal approach using a diamond drill, or utilizing a balloon, as I've shown and Ziv Mazur's shown on this site, utilizing the Miambi balloon device through the crestal approach. A lot of exciting techniques have been introduced over the last several years, incorporating very, very atraumatic and predictable sinus augmentation techniques, utilizing new tools that allow us to enter it more efficiently, with less trauma, and with less risk. Here you can see the vertical incisions at the end being secured and sutured with the vicryl sutures, and then the final x-ray at approximately 2 months before uncovering. You can see densely packed bone in the sinus in the area of the two BioHorizons implants, and you can see that the sinus has been well augmented utilizing this sinus graft approach. I'd like to thank you for taking the opportunity to share this video with me tonight, and I hope that it helped explain certain things that are critical to your own success with sinus augmentation for implant placement. I'm Dr. Maurice Salama for Dental XP, saying thank you.